experiences with implants and anterior implants. And before I start, I pass my gratitude and humble praise to my two professors who really changed my life. And because of them, I'm standing in front of you today as an implant surgeon. So it's thanks to Dr. ABHAY and Dr. Vinod Krishnan already take up a lot of basics and fine points about anterior implants and planning part. So I'm going to just brush it up so we can start away with the clinical cases. I got my first diplomate from Professor Kalmesh in 2005, and that was one of the landmark for me. And in 2016, I was included into the team of international CERACOP teachers and mentors. So, as Dr. ABHAY has already put it, this is a multidisciplinary science implants, and I strongly believe it has a prosthodontic base, but it has to be assisted by the team perio and oral surgery, as well as the maintenance phase. So, I'm going to talk about a little bit long-term cases I'm going to show you today. So, before I start, what is implant and how to achieve in success? My mantra is a planning. Strong point is planning. And it has to be prosthetic and surgeon planning to achieve what you are set to achieve, or what your patient demands are there, or what your objectives are. Then the surgical part, you have to develop your skills, or if you think you are not good enough, then you have to go ahead and learn from your mentors or your people who are teaching. Dr. Krishnan is already having a good center to teach or develop your skills. Then implant placements. And then the prosthetic delivery. I have to be ascertain which kind of prosthetic delivery the patient you are going to give. So before you start, you need to have the demand of the patient. That's the foremost. Onto that, you have to find all the clinical and medical evaluation, oral examination, that includes intraoral, extraoral both, radiographs. That's for single tooth, I still do 3D CBCT nowadays because of a lot of cases I'm going to show today where 3D, without 3D it was not possible. Diagnostic cast, I'm not going much into it. Already Dr. Krishnan has already touched everything in detail about it. And defining disease and prosthetic options. So once you have all these data on your table or on your computer, because of digital world. Now I'm going to show one or two cases of digital planning also. You cannot start the surgery. So whenever the patient walks into my office, I normally collect my data and I call my patient back again for the later date once I'm ready with the complete options. So definition of standards for aesthetic fixed implant restoration is in the harmony with the perioral structures of the patient that includes height, health, volume, color, and contour in harmony of the natural tooth or adjacent tooth. So to achieve that, you have to assess your risk factors. So already Dr. ABHAY has covered it in the morning in detail, so I'm not going to repeat it. So I'm going to touch upon a little bit of factors there with the clinical cases. So sometimes, in a conference, it becomes too much of repetition of theoretical things. So I was told to, touch on the basics. So I started with the thing, normally I start with my cases. So in risk factors, I think it's everything is covered by Dr. ABHAY. But here you have to look into the occlusion, which was not touched, bruxism, which is a very common problem. And according to that, you need to work on a lot of material, prosthetic materials. So development of titanium frameworks and polymer frameworks by HPP or graphene. All these factors are there, and that definitely put another dimension to the prosthetic options. So smoking. I'm going to show you a few cases of strong smokers, and how to achieve that. You have to do a lot of counseling with the patients to stop smoking, and once they give you at least a month without smoke, you should not touch the case, because I have seen for excellence for anterior, if you want to achieve that, you need to be sure that patient is not smoking, because all the flaps, bone grafts will fail because of smoking habit. So if your technique is complete, everything is good, but still smoking can take away all the credit. Now, the second is the high lip line, which is again a very deciding factor. If you have a high lip line, that's a patient expectation is sometimes really difficult to achieve. If you are having a thin biotype, that again becomes a double whammy, because thin biotype with a high lip line, it's difficult to maintain. Then the distance, a span of your edentulous area. So sometimes you do not have sufficient span. So in that case, you need to do a orthodontic correction first, or you have to see whether it needs to be corrected. If it is too wide, you have to see how you convince your patient why it was too high, whether the lateral incisors or central incisor or adjacent teeth are smaller in size as compared to a natural looking. So maybe you have to advise your patient for veneers or something, or a smile design. Multiple teeth, maybe 2 or 3, is the highest risk, because there you have mostly a bone resorption, buccal resorption, as well as vertical resorption. Also, as Dr. Krishnan just talked about, placing 2 implants side by side, because natural teeth normally in anterior region, they're very close by. There's not much of a space between 2 teeth. If you place 2 implants, and that too in the anterior region, and if they have in the later date, they will have a bone loss, because if you do not have a good vascularization, they're going to have a bone loss. So you have to select a tapered fine implant or a narrow implant to achieve a maximum interdental space there, or inter-implant space. So selection of implants is also very important. I've been practicing implant from last 24 years, and till date I never found a single implant system which can take care of every clinical situation. So when somebody says, okay, this implant works the best, maybe they can work for more than 60% or 70%. So I'm going to show you multiple implant systems today. I have few favorite implant systems, and I have reason to that. Another difficult or risk factor is your shape of your teeth, which Dr. ABHAY already said, talked about in the morning, the triangular ones, the risky ones. I'm going to show you few cases how to achieve without playing around with the crown shape, final crown shape, and to achieve a contact point, not a contact area. Because most of the people in private practice, they make this contact point into a contact area to avoid the black triangle there. So I'll have my own technique. I'll talk about it. Thick biotype is easier. Thin biotype is crucial. So you have to use a different treatment planning for that. I'm going to show one case. So, health of the teeth or infected sites. Chronic is not a problem, because body is already in, they have a mutual agreement. Okay, we take care of you and you don't hurt me much. So chronic infections are easy to take out. And normally bone is healthy, except some resorption, some grafts or particulate or beta TCP can help you in there. But if it's an acute infection, then you need to go forward with antibiotic protocol 24 hours before. And then you have to use a piezo surgery to make sure that you remove all the infection there. That's a different topic of another day, how we can use piezo surgery to do implants in acute infected inflamed sockets. That was my thesis topic for my master's in implants in Goethe University. I've already touched upon thick and thin biotype. You are aware of it. I'm in a perio study club, so I am sure everybody knows about thick biotype and thin biotype to handle with it. But if you see, a thin biotype is always a problem. The resorption rate is higher, and if it is inflamed, handling the flap is difficult. So you have to reinforce with the connective tissue graft. I'm going to show one case with a thin biotype where I have used a connective tissue to reinforce my gingival contour. Infected sites. Normally, I think it's not a big risk factor if the label bone is still there. But if label bone is gone, because of periodontal pocket or a periapical granuloma. Certain cases, I'm going to share one case where we'll do immediate implantation with proper planning and angulation, as Dr. Vinod Krishnan touched upon digital. I'm going to touch upon because I think freehand is not that easy. Digital, it makes it more predictable. The worst cases I have seen in my practice is these soft tissue anatomy where you have a resorption. And to create in thin biotype, it's a problem. So that's the level you would like to achieve. But this is where you have this 2 mm is difficult to achieve. So you need to have develop your flap surgical skills to achieve good optimal results. Now the crestal bone, and between the site and adjacent natural teeth, if your crestal bone is resorbed, that's a problem. Here I would like to use an implant system which I place little more deeper, not at crestal level, whereas logically you will think I should be placing implant at the bone level. Normally I place my implant submerged. I submerge those implants little more further, and I use block grafts to achieve or vertical grafts to achieve my bone loss. Because if you don't address to this problem, you're going to have once the implant is osseointegrated and bones start losing, I think it's very difficult. You have to then use a crown with the pink gingival contours. So in triangular crown case, where you have a bone loss, and then you have these kind of contact points, you have to address a 3D reconstruction there to achieve, or a block graft to particulate, or GBR doesn't work much good here. You need to use an autogenous bone. So these are also factors there. Label bone, how much thin phenotypes where you have very thin label bone and normally it resorbs. So a lot of techniques are in the, nowadays we use socket shield as one of the techniques. It's not indicated for all the cases. For certain cases you can use where it's still intact. So socket shield is one of the 3 techniques to achieve a optimal aesthetic results. But sometimes because of fractures or endodontic issues or chronic issues, socket shield is not practically usable here. So I'm going to show another case how to achieve thicker site, recipient site in these cases which are thin phenotypes, bone phenotypes. Bone anatomy of the alveolar crest. If it's really thin, anteriorly you can't do a bone distraction procedure very easily because you have adjacent periodontal space. If you try to do that, you're going to invade into the periodontal space of the adjacent teeth, or you're going to end up in not one teeth, start losing bone in the adjacent 2 teeth also. So here you need not to do, you have to do an additive procedure there, or a GBR or a block graft there. So these are very common cases where patient comes to you in a delayed case. And immediate loading is easier. So my point is that if the patient is losing the teeth or soon to be losing this tooth, immediately you should place implant where the patient has an acute or chronic infection, but after addressing to that. Because once you delay it, you're going to have a bone loss, and you have to do an augmentation procedure which is more expensive and time consuming. The worst kind of is this vertical defects in anterior where you have multiple teeth missing. These comes in high risk areas, and you have to do a vertical GBR or a distraction osteogenesis to achieve a optimal height before you place an implant. You can't place an implant and do the GBR. You have to first do the GBR and GTR, and then you have to do it. I think Dr. Krishnan has shown a beautiful case in the I think dentist keratocyst case, the young lady. So that's one of the examples there. Okay. So in a pre-surgical planning, what I'm looking at it, prosthetic planning we have done it, but pre-surgical you have to use soft tissue augmentation or a hard tissue augmentation. You have to make sure in your case what you need. So according to that you decide the type of flap or type of incision or site of incision. Then bone harvesting. If you have to harvest a bone, you have to recognize the site from where you need to harvest a bone, a type of bone. Because the bone in symphysis is different from the body and at the angle. So at certain angles, like if you need a J graft, you can't really take it from symphysis. This bone is really poor. You have to take it from an angle of the jaw because it has the most the probability of staying there for a long term. If you use a symphysis bone, it will be resorbed within 6 months. This bone will stay there for more than 2 years or so. So depending upon the site is also important there. So implants, types, positions and number. This is important. Dr. Krishnan has already touched a little bit. I would like to spend a little more time into it because every implant has its own plus points. Subcrestal, supracrestal, or at crestal. So all these implants have different bone stress or peri-implant bone stress according to the position where we place the implants. Number of implants and size of implants is also important. As I already mentioned, for maxilla, I always use a tapered implants because bone converged becomes narrower at the base. So if you use a longer implants, 2 adjacent implants, cylinder implants is not possible in anteriors. So you need to use the tapered implants. So placement of healing screws, stage 1 or stage 2 is important. Normally I place my implants in anterior with the stage 1 approach where I put the healing screw or a temporary crowns immediately. And suturing technique and material. So silk is not for implants. Mersilk is not. I always use either a PTFE or Teflon or I use Prolene. So individual prosthetics, you have to see our teeth are not round. And anterior is elliptical or triangular shape. So you have to mimic the nature to maintain the gingiva to behave in more natural form or stay there. If you use a round base abutments, you're going to have a long-term bone loss. And I have burned my fingers after doing very good cases and I'm placing a normal implants there, standard stock abutments which comes from the company and I start losing bone. And nothing wrong was in my surgery. It was more because of the selection of abutments. You have to use a customized abutments options for interiors and today digitally it is possible to do that. Earlier certain few companies used to give you aesthetic abutments which has a lot of heights and diameter variations which you need to mill it and do that. Sometimes you do castable but theirs not good. So nowadays we have better options. We do glass customized abutments, zirconia customized abutment, titanium custom abutments or pre-mills. It's all possible. You can even make one-piece screw retained restorations also. So I'm going to show 1 or 2 cases with that. So this is a very good material I use for temporization for immediate loading of my cases. And this gives very optimal result. This can be stained also, color also. So patient-centric treatment planning need to be done and I'm going to start with the cases today. Too much of theory is not good, I think, and already my colleagues has covered it. So this case, a patient came to me with a road traffic accident and she came with a lot of debris still poking out from there. As you can see here, the root stumps lying there and a lot of bone resorption and loss has happened here. If you look at here, we have lost the dimensions also. So after OPG, I took a CBCT and I found a complete neck roast bone there. So as Dr. Krishnan said, you should be ready for the surprises. So I always keep myself also ready with surprises. And then I did a little bit OPG planning because this is a very old case. That time there were no CBCTs in North India. I don't know about Kerala. So we used to have medical CTs and there's a lot of radiation. So as he was talking about Alara, Dr. ABHAY, in the morning, so it was better to, because medical CTs you have to repeat number of CTs. So normally I take 1 CT in the beginning and 1 CT only after 1 or 2 years. So this was the case I've taken and patient had a thin biotype with infected flap. So I use a Kazanjian flap technique here. It's a vestibuloplasty. I think all the prosthodontists, they know about it, perio. It's like a split graft where I increase the connective tissue fold for my soft tissues. Also, I need to do a connective tissue graft plus hard tissue. So this case needs a soft tissue graft, hard tissue graft, as well as a flap design, which is very typical and thin biotype. Thick biotype is easy to do Kazanjian, but not easy in. So once I did the flap raise, and there was a big defect. After cleaning the defect, it was roughly about, it's like a vertical defect, and middle of the bone, it was roughly 16 mm wide and about 11 mm deep. As you can appreciate here, there was a big defect after cleaning off all the debris and necrotic bone. So I've decided to take 2 ring grafts from the parasymphysis region itself, because I don't want to have big morbidity taking the ring grafts from the angle of the mouth. So I used roughly 11 mm trephines and took out 2 ring grafts, prepared the site. Here I prepped the site and collected some autogenous bone or cancellous bone, and filled my donor sites with collagen, because my connective tissue graft is going to act as a barrier, so I don't want to put it any beta TCP or anything, because normally it heals. This is not a load bearing area, so normal graft, even blood would have done the job. So I could have placed my implants also simultaneously using a ring graft technique, but in this case the position of my rings were not ideal for my implant placement. So I used bicortical screws to stabilize my ring grafts. I smoothened the margins here. After screwed it, I smoothened the margins, because any sharp margin on the ring graft is bound to fail the flap. So ring grafts need to be submerged 1 mm into the bed, not onto the bone. It has to be into the bone. It's more like a partially inlay graft where it is emerging out of the healthy bone. So after smoothing the bone, the ring grafts, I've harvested my connective tissue from the, I use a little bit of titanium mesh biocollagen membrane on the lingual side, because there's a groove between 2 circles. Normally, if you look, there's 2 grooves happening here in the anterior as well as in the posterior. So the anterior, I use a sequestered bone treated with the piezo surgery, and then I use it as a barrier for the anterior to make it a normal, natural looking slope. And the posterior, I use a titanium mesh membrane to prevent any soft tissue to grow between 2 ring grafts. Harvested the connective tissue between the premolar and the canine. This is the thickest connective tissue you can harvest from the maxilla. Normally in posteriors, it's so thick, but it is containing a lot of fat layer. So canine and premolar is the best site to have a connective tissue graft. So I use catgut to suture my connective tissue, because this is going to be submerged, and then later on I use Proline to close my grafts. This was the post-op X-ray. This IOPs were taken in succession for a few months, and this is post 8 weeks. So my ring grafts healed completely. The problem happened in this case was my connective tissue actually slipped lingually during healing. So I need to do a repeat procedure here. As you can appreciate here, my tissue healed, but still most of the connective tissue has moved lingually. So I need to move the lingual connective tissue, thick lingual tissue back to so that means I need to open the flap once again. So after opening the flap again, I have seen the bone is really nicely healed, removed all bicortical screws, and placed my implants ideally where it should have been. Normally I use submerged implants. Reason being to that is they prevent any bone loss or counter bone loss, especially in the grafted sites. So I repositioned my connective tissue grafts more facially once again, and remove my secondary screws or cover screws through the tissue. This implant system, you can use it without opening the flaps. And picked up the impressions. Nicely healed implants. This was one of the first zirconia crowns I made in my practice. So patient had a little bit of oral hygiene, but this is, reason being is that there's no function. That's why there is a tartar there. Because normally function comes in, the tartar normally doesn't come there. So you can appreciate the thickness of connective tissue and nice health of the connective tissue around my implants here. So this is very important to create a peri-implant thick connective tissue band, especially over grafted bone. If you want to retain the bone, you need to have a thick connective tissue, especially in a thin biotype. So these implants were there, and level of the bone is being maintained here. So this patient went on, she's a dentist, pathologist, and she works in Army Medical Corps. So another case is there where I had a insufficient space, and this patient has undergone orthodontic treatment, and then she left the treatment in between. She joined the college, and she didn't find time to go again orthodontic treatment. She wants the implant now. So we did a 3D assessment of the site, and to us, this is a problem here, because if I had the height of bone available there. If I used a 13 mm implant, I would have gone into the periodontal space. So here is very difficult to find which system has degree of taper that at 10 mm it will pass through it. Okay, so bicortical implants, I don't do it, so that can be managed, but I don't know, I don't use those implants. But to do a regular classic implant, you need to have a library. So I use a digital planning, and in a digital software, I can choose a system which is most ideal for this. So Noble Biocare 3x10 system was ideal. It was going perfectly between the two narrow space. So I had a space of 3.41 at the crest and 1.94 at 10 mm. So that was the implant I chose, and after digital planning, we choose a guided surgery in this case to save as much as soft tissue and hard tissue I can, because if I open the flap, I'm gonna have a problem there. So after I digitally planned the case, got the guide and placed my implant. Here the catch is there. I keep my sleeve very much away from natural teeth, because for example, I give you which gun is more accurate. I'm from North India, so it's a gun culture there. So in our family, I think I've seen a lot of guns in my family. So longer the gun, like sniper guns has a really long barrels. And the personal weapons like pistols and this thing, they normally have short barrel to shoot from the close range. But you want to shoot for a longer range and you want to be accurate, you need a long barrel. So here also in guided surgery, you need a long barrel, means you need a long sleeve to keep your drill, because under vibration, it will wave. And if you do not have a long sleeve to hold your drill, you're gonna go into the periodontal space. So this is my tip to you. If you're using a very narrow space where you want to put a very precise implant, always use a long sleeve, okay? Sniper rifle, remember that. So I used a guided surgery principle to place my implant. As you can see, I was able to save both the periodontal space here and place my implant. I use a little bit of laser to contour it. That was the day one. I put a TLOCAD crown same day to give a good optimal soft tissue and a growth of interdental papilla, because there was no interdental papillas, so to need to be created in a triangular teeth, because this patient has a triangular anatomy, so I need to create a papilla. That's why I need to do a temporization on the day one, the day I place the implant. So if you need a interdental papilla to walk in to create a prosthesis, with the same contours and leave it there so soft tissue should grow into it. Because if you close it and stage 2 approach, then you do a healing screws, and healing screws again round, so they kill the anatomy. So you either have to customize temporary or healing screw, a triangular healing screw, or a temporary crown. So anterior, if you have a good stability, I think Dr. Krishnan has really nicely put it there, why you need a quality of bone there to have a primary stability. So you have a primary stability, then use it. So I customize the crown. So my final crown is it called one time one abutment concept. Here we do one abutment at a time. We place only one abutment at the time of the implant placement, and we never remove those abutments. We use only the crowns. Crowns only is changed. So abutment is never disturbed not to disturb the peri-implant tissue there, or peri-implant tissue. And as you can appreciate, the bone is already start walking into the space because I use zirconia abutment, and it's moving. It's letting the bone walk up. And you know, soft tissue always follows the hard bone. And if you create a space for a biological width for a gingiva, bone will come in there. If you compress the gingiva, bone will go down. Some people, they say we had a bone loss. It mostly depends upon your prosthetic design of your crown. If your crown is not properly designed and it is compressing on your soft tissue or contact area or call area or contact point area or interdental papilla area, it's going to push it down. And if it goes down, it will take the bone also down. And when the bone goes down, your implant is exposed. So that's why I prefer to use a submerged implant, so counter a little bit of my soft tissue handling later on. So this was the 3D results of and you see I have not lost any bone, which was normally in thin bone, if you place your implant, the bone normally goes off from the margins. So this was the patient's final crown later on with a nice aesthetic results. I have not lost the level of bone. This is post 1 year, the second year. Now this is a case where we have a chronic infection happened because of periodontal or endodontic failure. Patient had, is 44, was long time back, now she is 50 years old. So this case is pretty old. It's done in 2015 or 16, I think. So this is the case here. As you can see here, we had a no label bone here. But the good thing here is we had adjacent, if you look at the mesial and distal bone levels, they were pretty good. So they are as good as any normal extraction site. Because only thing which is missing here is the label bone, but I haven't lost the interdental bone or mesial or distal bone. So here I can load the implant immediately. But if I would have lost this bone here, then I would have to do a GBR first. So here I place my implant digitally, angulations, surgical guide, again a long sleeve, a sniper rifle sleeve. And I chosen my implant system here was a braid end. I was trying my hand with the braid end implant that time. This was a crown which was looking nice earlier, but there was a nice periodontal pocket here. I used a tunneling. A lot of people, they say how you'll remove a granulation tissue without opening the flap. I'm a very conservative dentist, so I want to finish it fast. So best thing is you raise the flap with a tunneling knife and slip a BioGuide membrane there. So if the buccal periodontium or periodontal or periostem is infected, it stays out. Okay, the barrier membrane is keeping it out. So I need not to open the flap and remove all the granulation tissue and waste my time there. Whatever I can remove, I'll remove it, but still some remnant is there, still I can prevent it by using a barrier membrane. So I used my guide and placed my implants. As you can appreciate here, I placed the membrane here and collected some autogenous bone while drilling and placed some autogenous bone over my implant surface and let the blood walk over my implant first, then autogenous bone. Because if you put a xenograft or something, a dead over dead surface, do not expect a good bone there. So I normally placed first autogenous bone, blood, autogenous bone, and then a late resorbing bone graft, which is xenograft, and a membrane there. And I used vertical locked suture to keep my suture line stress-free, and placed my healing screw for clot to mature a little bit, and told my patient to wait for 15-20 minutes, and then I picked up an impression. Chances of using an impression material, digital was not possible. My digital scan post was kind of nearly submerged in the soft tissue, so I was not able to take out a good digital impression. Impression material is not advisable because you can actually contaminate the site. So I used a simple old technique which I learned from my college time. One of my seniors is sitting here, professor. So there we used to use this as a guide. We use temporary crown bridge material or normal cold care acrylic to just tell the patient to bite, to take a small jig. And I used impression post, and I picked it up and transferred it to my study models. Dr. Krishnan used a very sharp tone when he was saying diagnostic cast. So, that means, when somebody put a weight behind it, that means it's important. So my diagnostic cast here, see, I made a diagnostic cast. Still, I have a digital everything. Still, I made a diagnostic cast because this comes as a savior. I used it as a guided surgery on my diagnostic cast and transferred my jig to the diagnostic cast and placed my analog there and placed an abutment there, and I finished it. And then I scanned it and make a digital crown there, a teleocad crown. So this abutment is going to be there permanently in the patient's mouth, and only the crown will be changed later on. So this was the results. As you can see, the GBR, a black line, as you can appreciate here, that is the bioguide membrane, and this was a bone graft material, and a little bit of autogenous bone there. So this was the OPG, and this was the X-ray taken after I finished and before I sent the patient back. Now, I little bit augmented bone interdentally also. This was post 1 month, post 3 months. This was the soft tissue post 3 months. Patient came for the final crown, so I took the X-ray. And this was the day the patient has the final crown. Can you see the cortical plate coming back again? Natural shape of a alveolus. So this is what you can achieve, even your situation, by doing a good planning. What is there? Physiology, bone, soft tissue. You have to put all that science, put it on the table, and then put it in a planning. So it happens like a machine work. And this is getting better after post 1 year. So this was the optimal result. I got it after planning a little bit in a 3 to 4 months. And I think this is pretty good. Now, if you have lost the bone, is it the same approach? No. Now, this is a case, we had a lot of red flags here. Poor oral hygiene. Patient is a thin biotype. She's from Kerala. She was working as a scientist there in Indian Oil there. So, and patient has a little bit of this mobility since long. So now she has having a problem eating her non-veg food or biting onto the thing. So she came over and she stopped chewing actually from the front, and that led to a lot of plaque formation in the lower teeth also. So these are the difficult because you have more space available for a natural tooth to come in. So you have to adjust a little bit of thing. Not that much that where you need to do an ortho treatment. With this condition you can't do ortho treatment. Patient had other problems also. So you have to address those problems. Also, the plus thing is that the patient had impacted molars. So either I could have removed those molars remove the enamel and cement and use it as a block graft. This is one option. The other option was to take a block. This is not possible to take out any graft from the anteriors because very thin cortical plate and there was no bone, more like a fatty, because this lady is nearly 50 years old. So most of the spaces are fatty marrow. So the bone is really poor. So if you take it out, it will just stand like that, can't keep its integrity as a block. So you need to take it from either a ramus, angle, or molar. So I talked with the patient. As you can appreciate in here, we have lost bone here, height, vertical crestal bone is also lost. I have lost label plate completely. So this case is, I could have done this case immediate loading, but this case I've done in 2010-11. So that time I was a little bit scared of using a digital format and everything. There was no digital available that time. So I did a planning with the OPG. I did a ring graft from ramus because patient doesn't want additional cost of impaction molar to be removed. So I removed a little bit of connective tissue from the palate, actually third molar. I just used a trephine, suck on the third molar pad area and took out a little bit of the connective tissue there as a collagen ring and collected all my grafts before actually I did the surgery. I collected, harvested my bone grafts, connective tissues, and the sites. Closed it. And this was the tooth. As you can see, there was nothing left. This part of that is also granulation tissue. So I have to debride the tissue area with a bone curette. And I use piezo surgery. I use normally 10:1 ratio, 1:5 ratio of metronidazole with saline or a plain triple distilled water as my irrigant, and I used, kindly note down, sonoporation and read about it in Google. You will come to know what I'm talking about it, because if I use ultrasonics, it has a property to push the tissues without, or opens the cell walls to push it without really opening it. And the moment ultrasonic is removed, the cell wall closes down once again. So I use it as to make an antibiotic bank or remove all the inflammatory cells around it. And if somebody wants, I can share my thesis also with you. And I removed that and I collected a little bit of autogenous bone from the ramus area. I put it in the socket and used the ring graft and used a hammer technique. After prepping it with the trephine, I placed my ring graft and tapped it. It was a complete cortical block. Now if somebody will ask me, what decides the type of bone formation? Is it the bone graft which you use or the BMPs? So BMPs is very crucial. From where the blood is coming, that site decides what kind of bone will be or replaced bone will be formed. Whether you use a cortical bone or anything, and the bone will be converted to the blood or BMP which is coming to that site. So this cortical block will be completely replaced by cancellous bone. Once I placed it, I placed a little bit of non-resorbable bone graft material. That was the time I was fooled by Nova Bone people that it's a great bone, but it's a periodontal bone, it's not for implants. Anyhow, I didn't use it as a graft, I just used it as the top bone. I placed it and put a ring there and sutured it. This was the x-rays I've taken. IOPAs are the best to, place that's a day 1, first week, 4th week, this was 2nd week, this was 4th week, and where's the bone? This is the 8th week. So there's another thesis topic for any PG you want to do. I can help you out, because my every case you can find one thesis. So here I have used that time a simple, I didn't have a digital system, so I use a normal glue and stick it there. So again, when patient came in, a lot of plaque and so I had to again do scaling. So every visit I have to do a scaling and motivate my patient. And that's why there's a lot of inflammation and bleeding. But I opened it up and let's see, there's a little bit of cortical, so I was a little bit of scared that block is still there. But then I used my drill to find it out. It was a completely vasculite graft. Only the top ring was cortical. Rest of it has been replaced by a cancellous bone. Placed my implants. collected a little bit of autogenous bones once again and placed a little bit of it, and rolled over technique or soft tissue technique. This was a bone chips, I got it from the implant bed. Placed my bone graft and healing screw. So this should have been a customized option, but that's a very old case, so I couldn't customize it. Implant placed. This was the day one. As you can see here, this was the actual bone level here, and I placed my ring graft somewhere here. This was the bone level there originally, and this ring graft as bone somewhere here. So do you think periodontia will develop on the adjacent tooth? If you can appreciate, I have a periodontal space coming back again here. So how did I do a reverse of periodontal principles there? I didn't do anything. I just used a soft diamond tips, piezo tips, and removed the, or root planing you call it, remove the infected cementum from the adjacent root and place ring graft when I was doing it. So tissue responded to the graft, and I have a periodontal space coming back again in my adjacent teeth. So another thesis topic. So this is the kind of soft tissue I got it, peri-implant tissue. And here I use an elliptical crown or abutment. As you can see, it copies exactly like natural teeth. It's more like elliptical. And I place the crowns. Yes, it's titanium. That time we had only titanium. And the crown was placed. So it was still, soft tissue was not there, but it was promising that it will walk in. So this case was done in 2009-10. This was the day of that loading. It was done in 2011. Let's see how it happens after 3 months. The bone is there and it's actually start climbing. So this is the day I started, bone graft, first implant placement, the bone healing, crown loading, and this is post 3 years. Let's see what happens after that. So after 3 months, this was the condition. 2012, next year, bone is still there and is climbing up. This was the condition there. 2013, start walking a little bit. 2016, bone is still there, exactly how it was. It looks like a repetition of OPG, okay? No change. 2019, my OPG system changed. This is 2021. So it's remained stale, and now you can see the nice contour exactly like adjacent tooth. We have it there. So this, I would say, optimal results. And this was the bone still there, a thin line, the ring graft is still there. And this is the bone condition in 2021. There's another case, orthodontic, sir was talking about concavity there. Okay, let's see one case there. How difficult is there? Let me put it, what he touched upon it, why he stressed on it, which tooth has a lateral, concavity and anterior, lateral incisors. You know, he put a lot of weight behind it, because he has a reason behind it. It's not that easy to do that. So there's a lot of bone loss here. Adjacent teeth were, laterals were missing congenitally. Height was optimal, but width is not. So after orthodontic correction, we created a space, and as you can see here, we had a lot of concavity. And thin band of cancellous bone, thick band of cortical bone, so implants were not easily possible there. So splitting, if you try to do a splitting of this case, you're going to lose that bone also. So it's more of an additive procedure there. So place 2 implants, tapered implants, and a lot of GBR, means I placed some xenograft there, and some membrane there and closed it. So you can see how much amount of bone graft I placed it there. It was a mix of cortical chips with xenografts. And then this was 1-2 and this was 2-2. This is after 3 months. This is 6 months. Then you can see the bone after 6 months, 1 year. This is after 2002. This was done in 2021, I think. So you can see here, a lot of bone is remodeled. I'll go one slide back. As you can see here, the lower one also. I had actually a complete length of implant exposed, some autogenous bone and GBR. Let's see after 2021 what happened. So natural anatomy is coming back. So this is 2021 picture. No, this is the day we loaded and that was 2016. And this is 2021. We have nice natural teeth. Orthodontic couldn't close it, but natural teeth had black triangle, but not the implants. So this is the patient smile. This case is another case. I think I have time. Wait. So this patient had a fall, and young lady lost her teeth because of internal resorption. And she lost actually everything. The bone, everything was gone through and through, from buccal to palate. So no way I could place the implant here. So I placed again a ring graft. In this ring graft, I placed the implant bed already, the position. I placed some, this is, I call it red gold. The blood from the site I collected. And in that site, I placed my ring graft for some time to soak my graft with the BMP-rich blood from the site. Placed my implant ring through it, and rest of the space, I just left it there for the blood to take care of a bit of cancellous bone. These are all old cases with a follow of 10 to 15 years. And this was a gingiva, I achieved it. This was the crown placed, sorry. This was the crown placed. Then this was the patient on the day I placed the crown. It's running fast. Anyway, this is, patient came to me after a gap of nearly 7 years. And that time she came because of chipping happened in the anterior crown. So I took the CBCT. This was the IOPAs of ring grafts. And this was the 2015 X-ray. And this is a 2023. So I think I didn't lose any bone. Actually gained. This was an aesthetic crown made in 2023, January last year. And was given to the patient with the optimal results. This patient came to me with a history of substance abuse, smoking, and drugs, and referred to me by my friend, who's also happened to be a dentist. And this patient was given some implants that time. The lower teeth and upper teeth were treated by his brother, who's a dentist, some root canals and crowns. And we gave him some bridges and crowns. Then he came to me in 2014. The lower implants were doing fine. The patient had some problem in the front teeth. He was complaining of some tingling sensation while biting onto it. So 2016, it looked fine to me. I changed some crowns, looks fine. And 2016, he complained of gap coming in. The fracture roots were there. So anterior fracture roots were there. We had to remove all of them with the infected chronic infection. When he came to me in 2014, the roots were fractured. I couldn't diagnose it better. I should have with the CBCT. But I tried a normal CBCT, maybe because of endodontic restoration. A distraction happened in the radiograph or CT, and we couldn't appreciate the fracture line. but then we had a granulation tissue. We removed all the granulation tissue. Luckily, they're all stripped very nicely, and I did the guided surgery placement. Purposely, I placed my implants of little different angulation, 5-degree separation because anterior I want to load it. And then I used multi-unit abutments to make them parallel and place some bone graft material, late resorbing bone graft material, xenografts, to maintain my buccal volume. I don't want the buccal. Most of the time, if you place your implants, the bone resorbs and the buccal volume goes down and your implants either get exposed or you have lost the architecture. So placed my crowns, gave a temporary crowns to the patient with a little bit of prosthetic scallop crowns, Pontics. A little out of occlusion that time, and the patient came back after 2 months, and I gave them a nice titanium framework crowns. Now you can appreciate I created the papillas first and the contours. I maintained the volume of the teeth and placed 2 screw retained crowns. This was 2016-17. I had the stable bone. This was 2018, next year. 2021. This year I lost my patient. He had a heart attack and he expired, but this was 2021. He had a nice, stable anterior profile. So this is from here. I was treating this patient. I achieved this in 2014, and this is 2021 when he left. So if you maintain the data long term, as Dr. ABHAY was talking in the morning, that you should maintain all your data. I'll take 2 minutes. This case is a patient, a diplomat, was having a dinner in the President House. And I think our President House cook gave them some concord in the chapati, and I don't know, some stone came in, and I didn't know that level of President House is so bad that they had stone in that food. And crack, this lady from diplomat's wife was referred to one of the doctor which is connected to President House. And this patient wanted the same day, and they said, okay, you go to my friend, he has an in-house lab, he can give you the same day some solution. The patient came to my office, and this was the temporary condition was this. So I used this as a digital framework, and I copied it on a digital framework. And she had a high lip line. I think that was the reason why my colleague referred it to me. So this was a digital planning done. As sir was talking about it, you place your implant anywhere, tilted implants. As far as you are able to prosthetically parallel them. Your angled abutment, you have to plan in advance that they should have a same emergence profile where you want it, not buccally or lingually, should be in the middle fissure. So I planned my implants. As you can see here, my implants, wherever the available bone was there, I placed my implants. Bone was really bad, so I couldn't augment it because the patient had to go back. So I planned that way. And in the lower anteriors, posterior, I do immediate posterior loading, functional loading. This is my protocol. Sectional, I do it, not full mouth. Even section, you can possibly do it. Maybe tomorrow SPIK will call me once again to talk about this. So that's another protocol. So as you can see here, if you look at my surgical guide, it will look like one crown is going to Cochin, one to Ernakulam, one is to Trivandrum, one is going to Kanpur. But actually, all these implants are within the ambit of 30-degree angulated abutment. So I was able to make all my abutments parallel. Digitally, I planned that way, because in software, you can make them see in advance, okay, these implants, the angulation between one section to the other section, how much is the difference? It should not be more than 30 degree. Because multi-unit abutment can take 30-degree variation, not more than that. So placed my crown, this was a crown copy. I saved it as a catalog because patient doesn't want his smile to be changed. So I used it as a catalog and saved it in my software, made a surgical guide, placed my implants, removed all the infected broken teeth, and As you can see now, all these implants look parallel because of multi-unit abutments. This was a temporary given to the patient, and this was a temporary. As you can appreciate here, all screw holes are coming where it should have been. Now, all my implants, none of the implants are parallel. So this was given to the patient and sent. Later on, the patient came back. This was a process given to the patient, and she was very happy with it. She wanted a pink looking gums. Anyway, that's what she wishes. And these were the crowns. This is my office where I work. One is my surgical office. I have a scanner there. I sometimes use intraoral scanning while doing surgery to scan it. So that is a simple scanner to scan. The other is a chairside dentistry office. This is my in-house lab and TBCT and other things, which helps me in giving process to my patients. This is my team members. This is my team. Without this, I think, without team, you can't. I have my periodontist here. Without periodontist, I think I can't do implant practice. I need to have a periodontist close to me. So Dr. Divyaraj, he is a periodontist colleague from alumni from Manipal itself, and then other team members are there. So knowledge can only be got in one way, the way of experience. There's no other way to know. This is how I learned. This is my spiritual guru. Other than Dr. Bhatt and Dr. Verma, and Dr. Balagopal Verma, he's also taught me. Matthew sir is also there. So, Jai Hind, thank you.